I've been practicing for quite some time now. There are moments when we did not have capnography and pulse oximetry, all right? And bad things were happening. For example, we would take a child to radiology for CT scan, and children need to be sedated as they go to radiology for CT scan. But if you do not have a pulse oximeter, then you are blind. You don't know what is going on with regard to oxygenation and ventilation of this patient. So we lost one child just because we were not monitoring oxygen levels in that child. And I'm speaking this as a head of department. It's my team members who are with this child. And then another example is a lady who had a lump on the breast and she came for surgery. And unfortunately, the anesthetist in that room did an esophageal intubation. There was no capnography and no pulse oximeter. And it was late when the surgeon discovered that blood was really dark. And then they discovered that actually that patient had cardiac arrest and they could not bring back that patient. Now, these are equivalent to cases that we do without pulse oximeter and capnograph, and they are quite common upcountry, because I'm speaking about a referral hospital here. And what about all those district hospitals upcountry? After introduction of pulse oximeters, many other incidences occurred, and we handled many critically ill patients. For example, there was this a mother who came to deliver, and she ended up having cervical tear. Okay, so that was repaired. And then the patient was taken to ICU because she had already bled a lot, but she continued to bleed in ICU. And so we sent the patient back to the OR, and a hysterectomy was done and drainages were put. The patient was brought back to ICU, and this time she was mechanically ventilated. But the drainages were draining too much blood. So we took back the patient again and for exploration and hemostasis. And then this patient was, the bleeding was arrested, and the patient was brought back to the ICU. But now she started developing some features of acute kidney injury, all right? With retention of fluids and hyperkalemia. We tried to treat the hyperkalemia pharmacologically, but it didn't work out. And when we had decided to take the patient to dialysis, she arrested, okay? So long story short, this mother arrested 3 times. In ICU, we resuscitated, she came back. In the lift, we resuscitated and she came back. And during dialysis, and she came back. Overall, she underwent about 6 dialysis sessions, and she stayed in ICU for about 10 days, and she fully recovered and went home. But during all this journey, we had a pulse oximeter on, and the only pulse oximeter that was used in the OR during transportation, in ICU, and during resuscitation and during dialysis sessions, it was a Lifebox oximeter. And you can't ventilate these patients. You can't provide oxygen to these patients without it, okay? But by then, Lifebox did not have gadgets that could do both. Monitor saturations and carbon dioxide levels. And I'm glad now they are coming up with a gadget that can do both, because we really need it in many hospitals, not only in upcountries, but also in main hospitals in our cities, because we need to transport these patients, and that we can use those portable devices to do that. And also, when our main gadgets malfunctions, which happens a lot, we can actually pull out a pulse oximeter, pull out a Lifebox capnograph, and continue to monitor patients who is under care.